Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Hi, how are you? You found your way back to yet another episode of the Mod Pod, and that makes us happy. Thanks for joining us. Love it or hate it, it's the start of pumpkin spice season, and you know what that means. It's time to share some articles from Mod's September issue. Let's start by hearing from Thomas Cheezum, manager of Tidewater Optometric Consulting Services in Virginia Beach, Virginia, who co-wrote our first article on post-pandemic opportunities for telemedicine with Justin Schweitzer, an optometrist Advanced Thompson Vision in Sioux Falls, South Dakota, and Walt Whitley, director of optometric services and residency program supervisor at Virginia Eye Consultants in Norfolk, Virginia.
In just a few short months, telemedicine has become a vital service offering for our patients and our practices. Although telemedicine has been around for years, the COVID-19 pandemic was a tipping point for eye care providers to embrace the technology. Telemedicine has given us the ability to connect with our patients and colleagues to provide accessible and timely care in a convenient, socially distanced manner. Now that eye care is reopening and we are all ramping up our offices, some questions do remain. What opportunities will exist for telemedicine in our future practice initiatives? Will we let it fade away or will we take it to the next level? With telemedicine, as with many factors in life, we can choose to either take a reactive or proactive approach. No matter the approach, however, telemedicine is not going to wait for us to decide. Our ability to provide eye care remotely through problem-focused exams is something that patients appreciate. Although the technology may now be limited in scope, we must look forward to future possibilities for optimizing patient health. Deep learning and artificial intelligence may seem to be concepts of the distant future, but they are already here. Consider the IDX Doctor, an AI technology capable of detecting more than mild diabetic retinopathy with high sensitivity of 87% and specificity of 90%. Or consider the AI software Pegasus, which can detect glaucomatous optic neuropathy with an accuracy of 83.4%, compared with ophthalmologists and optometrists at 80.5% and 80% respectively. These technologies will enable doctors to provide care in a more efficient manner, thus allowing more patients to be seen. Although they are not yet available on the market, these technologies and others like them will surely play a role in the future of eye care and telemedicine. Knowing that telemedicine technology in eye care is only going to improve, we must consider now how we can implement it into our practices to be ready for the future. Many of us have dabbled in telemedicine, and some have had more success than others. Imagine if we fully commit to implementing it into our practices and have it available to complement our in-person services. In our new socially distanced world, we need to continually reinvent ourselves and our practices to find new ways to care for existing patients while attracting new ones and establishing new income streams. Failure to embrace telemedicine's benefits may allow other entities to remove certain aspects of practice from our control. The following are a few ideas for incorporating telemedicine into our practices in ways that allow us to bill for the services. Phone consults with other providers allow us to get opinions on our patients' conditions or interpretations of tests and images. Although not yet common use, interprofessional codes are available that both referring and consulting doctors may use to bill for care provided for the benefit of the patient and being reimbursed for their expertise. Many primary care physicians are using telemedicine for patients with diabetes and sending fundus photos to a reading center to screen for diabetic retinopathy. Whether you provide the interpretation or you send the image to a reading center, the image is only one part of the examination. Many patients still need a referral for detected diabetic retinopathy, glaucoma, or other ocular conditions such as decreased vision or glaucoma. After initial fittings, we can use telemedicine to follow up with contact lens patients. Communicating with our patients in this way, we can help ensure a successful fit, address questions and concerns, and perform a gross evaluation of the contact lens fit. These services would likely be included in a global fee for the initial evaluation, fitting, and progress check for new contact lens patients, or new contact lens designs for established patients. Established contact lens wearers with acute problems could be evaluated using codes 99421 or 99423. Telemedicine can be used to care for both new and existing patients with dry eye. We are advocates for point-of-care testing, which obviously cannot be performed during a virtual visit. Nonetheless, we can still obtain a history, review medical history, discuss previous treatments, and initiate therapy. A common scenario in which telemedicine can be used is in virtual follow-ups. There are many effective and safe medications available to our dry eye patients, and we can prescribe as indicated and follow up 4 to 6 weeks later to check on their progress using questionnaires such as the standard patient evaluation of eye dryness or the ocular surface disease index. Telemedicine can be used for some diagnostic testing services for chronic disease management. For some follow-ups, patients can be scheduled to come to the office for testing only, such as OCT, visual fields, IOP checks, dark adaptation, or other electrodiagnostics. This type of hybrid evaluation minimizes the amount of time the patient is in the clinic. The patient can then be later scheduled for a telemedicine visit to discuss treatment and management considerations. Another option for glaucoma care is the eye care home tonometer. Patients can either buy or rent this device to take daily IOP measurements at home. There are also visual field options for at-home use in virtual reality platforms or platforms for tablets or PCs. Communicate with your surgeon to see whether virtual visits can be used to replace a day 1, week 1, or month 1 postoperative visit. Although this is not the traditional standard of care, it may be used to limit the frequency of office visits for the sake of safety and social distancing. One caveat for these virtual visits would be to have a lower threshold for identifying patients who may need to be seen on the same day. There are no current telemedicine codes that can be billed during a global postoperative period, but this may change. For practices with multiple providers and limited space, developing a telemedicine template can be an opportunity to allow all providers to stay active while maintaining social distancing. Consider bringing patients in for testing-only days and then scheduling a telehealth visit to review the data and treat accordingly. Offering virtual services can be a way to attract new patients. You can promote these services on your website and in office materials, in addition to offering them to patients for follow-up exams when appropriate. In the current environment, many patients want clinically efficient healthcare delivery via virtual platforms. The availability of these services may also encourage patients to contact us first when they have an urgent or emergent ocular problem, rather than their primary care provider, or possibly worse, traveling to an emergency department where the doctors may have little experience in the diagnosis and treatment of eye conditions. No technology can replace the care that we provide our patients in our offices. From a remote examination alone, we cannot acquire the magnified views of the anterior segment that we can at the slit lamp. We cannot obtain IOPs or analyze the optic nerve and retina remotely with current technologies. What's missing even more is the physical touch, the empathetic ear, the bright smiles, and the candid conversations we never can be replaced virtually. Nonetheless, we have a great opportunity to strengthen and grow our practices through the use of telemedicine. Our profession faces numerous threats, but virtual care provides a chance to strengthen our relationship with existing patients and to develop new ones.
Knowing that telemedicine and eye care is only going to improve, ODs must consider how they can implement the technology into their practices to be ready for the future. Are you prepared to take it to the next level? Next up, how about a lesson on neurologic visual field loss? the incidence of visual field loss in the general population increases exponentially with age. Jacqueline Theis, neurooptometrist at Virginia Neuro-Optometry in Richmond, Virginia, and affiliate assistant clinical professor at UC Berkeley School of Optometry, provides some helpful points to consider when evaluating a patient's ability to drive.
Eye care providers are often given the daunting task of assessing whether a patient is visually safe to drive. Although every state has definitive guidelines regarding visual acuity and driving, recommendations for patients with visual field loss are less specific and in some states don't exist at all. This leaves great responsibility with the eye care provider, which is exponentially increased when a patient has neurologic homonymous visual field loss with 20/20 visual acuity. For the purposes of this article, neurologic visual field loss is defined as the loss of visual field due to a non-ocular lesion along the afferent visual pathway. Unlike ocular visual field loss, neurologic visual field loss can be accompanied by and influence perceptual, cognitive, and motor dysfunctions, which must be taken into account. The incidence of visual field loss in the general population increases exponentially with age. Stroke is the second most common cause of visual field loss in the elderly population, second only to primary open-angle glaucoma. Depending on the study, 20 to 67% of stroke patients have some type of visual field defect. Of those patients, 50 to 73.5% present with homonymous hemianopsia due to an occipital lobe lesion, 15% to 30% have homonymous quadranopsia due to parietal and/or temporal lobe lesion, and the remaining patients have other visual field defects due to lesions involving the optic tract or lateral geniculate nucleus. Although we often evaluate the extent of neurologic visual field loss, i.e. degrees of visual field lost, and best corrected visual acuity to determine driver safety, only 31% of patients with neurologic visual field loss present with visual field loss alone. According to Rowe et al., 28.6% of patients after stroke had visual field loss along with reduced vision. 28.2% had visual field loss accompanied by ocular motor abnormalities, and 25% had visual field loss and visual perceptual difficulties. These ocular motor and visual perceptual dysfunctions can directly reduce cognitive performance, undermining a patient's ability to compensate for visual field loss and challenging his or her capacity to interact with the visual environment. Patients with neurologic visual field loss may complain that their vision is slow, that they see objects too late, that they get lost in busy, crowded places, or that they are surprised easily as things such as small children or dogs suddenly appear and disappear in their visual field. Beyond driving, neurologic visual field loss can affect other tasks of daily living, including reading, writing, cooking, walking, visually guided motor movements such as grasping objects, and more. If patients do not adapt to their visual field loss, they will have an increased risk of falling and may feel unsafe navigating their own environment. It is important for eye care providers to survey patients to understand how visual field loss is affecting their daily lives. Don't be surprised, however, if patients say they are fine or are completely unaware of their visual field loss. Some 10 to 19% of patients may be asymptomatic or unaware of their visual field loss after a stroke. Although ocular visual field loss, such as a central scotoma and macular degeneration, may appear as an obvious dark spot to the patient, neurologic visual field loss can be less conspicuous to the patient, even though it is larger and apparent to eye care providers on automated diagnostic testing. In neurologic visual field loss, the brain may try to fill in what is missing, and some patients have described the missing area to seem more like a faint blur on the edge of their vision, rather than a large scotoma, as our testing may suggest. This makes it difficult for some patients to recognize just how much visual field has been lost, and can be confusing to caretakers or family members who cannot fathom why their loved one is unable to recognize and therefore compensate for their visual field loss. Furthermore, patients with damage to areas in the brain involved in visual awareness may even deny the existence of their visual field loss, even when confronted with it in the exam room, a condition known as anosoagnosia. The degree and type of unawareness of visual field defect can vary. In mild presentations, the patient is aware of a visual defect to one side, but may consistently misinterpret the visual field loss as missing vision in one eye only. In severe presentations, the patient may be completely unaware of the vision loss and refuse to acknowledge its existence, even when confronted with the test results in the office. Therefore, it is important not only to ask patients how they are coping with their visual field loss, but also to ask their family members or caretakers who may have a different perspective on the impact. In addition to awareness of visual field loss, every individual will perceive his or her visual field loss differently. Some patients may be able to detect motion in their blind field or scotoma, even though they cannot consciously locate or see it, a condition known as blind sight. Other patients may experience visual hallucinations in their blind field. This can be confusing for patients as they may feel they are getting their vision back or are seeing things that really aren't there. Interestingly, recent studies have documented patients with a condition known as sight blindness, in which the patient experienced visual perceptual processing difficulties in his or her normal intact visual field. Findings in the normal visual field of sight-blind patients include reduced contrast sensitivity, longer reaction times, reduced contour interaction, perceptual distortion, and difficulties with visual search eye movements that can lead to disorientation and difficulty avoiding obstacles. Although sight-blind patients may have normal visual acuity and a visual field restriction that falls within state guidelines for driving, reduced contrast sensitivity and reaction time may make them unsafe to drive and affect other aspects of their life. Eye care providers want to advocate for and empower their patients to see and do the things that they enjoy. It is important, however, to remember that driving is a privilege and not a right. Assessing whether a patient is visually safe to drive affects not only the patient, but everyone on the road. With conditions such as anosognosia, blind sight, and sight blindness as possible diagnoses, every case of neurologic visual field impairment must be evaluated beyond visual acuity and visual field testing alone. The more we can educate our patients about their vision, the more we can help them adapt and stay safe.
If you prescribe contact lenses, you probably encounter patients with some unsavory or downright unsafe habits when it comes to wearing or caring for their lenses. But how do you get these patients on the right track? We'll tell you after the Mod Pod takes a quick break.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
You're back just in time. Chandra Mickles, Associate Professor and Director of the Dry Eye Care Center at Nova Southeastern University College of Optometry in Fort Lauderdale, Florida, is about to explain how to reinforce healthy contact lens wear so you can make sure your patients develop key habits for safety.
An 18-year-old man presented with a report of painful red right eye. When asked about his wear of contact lenses, he reluctantly reported sleeping in his 7-day-old daily disposable lenses. Unfortunately, for many eye care professionals, this scenario is not rare. Despite the numerous benefits of contact lenses as a safe form of vision correction for millions of people worldwide, their misuse can put individuals at risk for sight-threatening and life-disrupting complications. Now more than ever, when a pandemic has made access to eye care different from normal, a busy practitioner's time is well spent educating patients on good contact lens behaviors and warning them about the high-level risks associated with poor adherence and unhealthy behaviors. This article highlights key healthy habits that we should strive to instill in our patients in an effort to prevent soft contact lens complications. Armed with the latest knowledge and strategies described here, clinicians and patients together can best ensure safe and successful soft contact lens wear. Now, patients are exposed to an army of microorganisms on a daily basis. Because of this, it is essential for them to wash their hands every time before inserting or removing their soft contact lenses. This is the first essential, simple step in preventing soft contact lens complications associated with microbial contamination. Poor or absent hygiene is a risk factor for both microbial keratitis and contact lens associated corneal infiltrative events. However, up to 50% of soft contact lens wearers do not wash their hands as directed, especially before lens removal. Hand hygiene is a fundamental, modifiable patient habit that can be improved with proper emphasis. Intuitively, daily replacement of contact lenses should decrease bioburden, including that from lens storage cases, multi-purpose solutions, and the eyelids. In fact, the use of reusable contact lenses is recognized as a risk factor for the development of corneal infiltrative events. Proper use of daily disposable lenses reduce the risk of corneal infiltrative events by 12.5 times. Chalmers and others demonstrated that the incidence of corneal infiltrative events for hydrogel and silicone hydrogel daily disposable lenses is very low, 0% and 0.4% respectively, compared to that with reusable soft contact lenses, which is around 3 to 4%. Although daily disposable wear is ideal, patients should be made aware that inappropriate use of this modality, for example, overnight wear, reusing their lenses, can result in severe corneal infection with an incidence as high as that of other modalities. Practitioners should prescribe daily disposable lenses when possible because should not become complacent regarding minimizing the potential risks. Every opportunity should be taken to safeguard patients' health, as with all types of contact lenses. Today, 50% to 60% of patients are fit with reusable lenses. For our patients in reusable lenses, optometrists must emphasize habits that will reduce the microbial load in their lens storage cases. Microbial contamination of contact lens storage cases is associated with a substantial increased risk of corneal infiltrative events and microbial keratitis. Continual use of cases and lack of lens case hygiene allows the lens case to become a reservoir of infectious microorganisms. Cases that are 6 or more months old increase the risk of corneal infiltrative events 8-fold, and poor case hygiene increases the risk of microbial keratitis 4-fold. Unfortunately, lens case hygiene and lack of replacement rank high as areas of soft contact lens noncompliance. Lens cases should be cleaned after each use and replaced at least every 3 months. This is a message that eye care providers must hammer home to their soft contact lens wearers. Studies show that an alarming number of soft contact lens wearers are grossly unaware of when to replace their cases, or to replace and clean them significantly less frequently than suggested. In these studies, roughly 3/4 of wearers were unsure when to replace their cases. Roughly half reported replacing their cases only every year or more than a year, and almost 1/3 of users cleaned their cases monthly or less frequently. Overnight soft contact lens wear is associated with a substantially increased risk of serious soft contact lens related complications, with reports as high as an 8-fold increased risk of developing microbial keratitis and a 7-fold increased risk for corneal infiltrative events. Moreover, overnight soft contact lens wear is a major risk factor for serious soft contact lens complications, regardless of lens material or modality. However, approximately 1 in 4 patients report sleeping in lenses, a number which is consistent across all lens modalities, including daily disposable lenses. Again, this is a message that we must deliver to patients. Exposure of soft contact lenses to water, whether through rinsing or storing lenses in tap water or swimming or showering with them in is a well-established risk factor for corneal infiltrative events and microbial keratitis, especially the visually devastating acanthamoeba keratitis. Unfortunately, soft contact lens wearers appear to be largely unaware of the risk of soft contact lens water exposure. In a study examining contact lens noncompliance, water exposure was the most frequent noncompliant behavior reported. Studies have shown that approximately 90% of soft contact lens wearers shower and 60% swim while wearing lenses. Roughly half of soft contact lens wearers rinse and or store their lenses in tap water, at least infrequently. We should be making it clear to patients that any form of water exposure can potentially lead to substantial vision loss. Increasing awareness of this risk is paramount. The noncompliant behaviors outlined above appear to drive the greatest risk of serious soft contact lens adverse events. However, other unhealthy habits can also increase the probability of an adverse event. Smoking, topping off solutions, self-pay or internet purchase for soft contact lens replacements, and wearing soft contact lenses when ill are other modifiable risk factors that we should be talking to patients about. Non-modifiable risk factors, such as a younger age, 15 and 29 years, male sex, history of a red eye event, and high refractive error should also be taken into consideration when making prescribing decisions. For example, an 18-year-old male with a history of a corneal infiltrative event should be strongly encouraged to wear daily disposable lenses. The Contact Lens Assessment in Youth CLAY Research Group's Contact Lens Risk Survey can be used to query patients regarding risk factors associated with soft contact lens complications. The survey will be available for use in the clinical setting in the near future. This survey is an excellent tool to help us quickly identify unhealthy soft contact lens habits and mitigate poor outcomes. Awareness of healthy soft contact lens habits is the first step toward a successful wearing experience. By connecting the value of safe soft contact lens wear to good health, we can invoke and maintain proper behaviors in our soft contact lens patients. Following are some tips to get new soft contact lens wearers on the road to success and to keep established wearers on track. So stress the negative, highlight the positive. One reason soft contact lens wearers are non-compliant is their lack of awareness of the consequences of their actions. Be sure to describe the benefits of compliance, such as comfort, health, and white eyes, as well as the risk of non-compliance, such as vision loss, infection, and discomfort. Outlining to patients how a specific poor behavior contributes to unsafe wear may help to prevent complications and misconceptions. For example, be sure to tell patients that over time, lens cases become invisible petri dishes, like toothbrushes. Explain that keeping a lens in a case with old solution is similar to bathing in dirty bath water. Descriptions like these may propel patients to replace their cases as recommended and prevent them from carrying around cases with old solutions for emergency uses. Patients appreciate jargon-free, concise, and clearly presented information. Their comprehension of information presented in this fashion can potentially improve adherence. It is best to minimize complex regimens that can be barriers to success. For monthly lens wearers, I have found that streamlining lens accessory replacement to a monthly schedule and sequencing instructions to fit in with a patient's morning and evening routines goes a long way. Illustrations, images, and videos can help in communicating the importance of soft contact lens safety and ensuring adherence. A picture is truly worth 1,000 words. When I show my non-inherent patients their corneal scars or videos of their grossly deposited lenses, it helps them to get back on the right track. Education alone is not likely to significantly sustain long-term behavior change. Regularly remind patients throughout the exam and throughout the year of the importance of healthy habits for successful wear. Repeated messages can be delivered in monthly boosters via social media or with reminder labels on lens cases. Repeated messages change behaviors. If possible, enlist others, such as family members, to reinforce the message. A repeated, unified message from those socially close to the wearer strongly affects compliance and emphasizes the importance of soft contact lens safety. One strategy alone will not completely prevent all soft contact lens complications. However, by elevating the importance of healthy habits in the mindset of our patients, we can help them successfully enjoy this valuable mode of vision correction for the long term.
Okay, we have one more to go, and this one was worth the wait. Mod's associate editor, Katie Herman, interviews funny man Marc Bloomenstein for our Up Close column. Find out if optometry was his first career choice, what about the profession interested him most, what he enjoys about making videos for Collaborative Corner, and more.
Was optometry your first career choice?
Actually, no. The irony of my career choice is that I really only had one eye examination as a teenager, not a very memorable moment at all. In fact, the optometrist who sat across from the room reading a paper, I think it was the LA Times, it might have been the Orange County Register, I'm not sure, it doesn't matter, because he really wasn't paying attention to me. He was more interested in the paper as well as he was not interested in my exam. More importantly, it was really right around the same time as the Iran gas shortage, and why that's really relevant is just because I remember that time so distinctly in the 70s. It was crazy. But I worked at a Sizzler restaurant, and honestly, I still miss that cheesy bread. We used to have people come in and just take the little shrimp and just peel off the breading, and then it would just be this little micro shrimp. It was awesome. But at that time, I was also working in hospitality, and I kind of thought that was more my speed. Hi, is there anything I can do to help you? Kind of, no, great, didn't want you anyway. When I went to college, I was immersed in the sciences. I volunteered at the Medical Center. I followed the race for an AIDS vaccine with really, a tremendous amount of enthusiasm and interest. It was something that I really thought I wanted to do. I spoke to my biochem professor about research, and it was interesting because she said, I don't think your personality is really cut out for a lab. And honestly, I couldn't tell why she said that. But I also realized too, not until I was rejected, and this is sad, but I still think of it this day, by my chem partner, when I was trying to see if she wanted to maybe hook up, and she was like, no. And she also was telling me that she was studying to be an optometrist, that I realized, maybe this is destiny. Maybe this is why I should be working in eyes, and kind of go back and change what the perception from my Iran Gate eye exam I had.
So what about the profession interested you most? When did you know it was the right path for you?
So, interestingly enough, optometry in the mid-'80s was just really starting to gain some therapeutic prescribing, right, nationwide, expanding the scope of the profession, and really allowing optometrists to practice to their full, educational heights, if you will. We really allowed people to soar because the schools were teaching way beyond what a lot of the states allowed them to do. And I knew that I wanted to work in the public, and yet not be tethered to a hospital. I mean, thinking back, I remember speaking with a couple of optometrists who worked in both corporate and private practices back then. I think the consensus was that it was a great profession. I mean, patients leave the office, especially with contacts, with a tangible improvement in their vision. I didn't really talk about the vision therapy or things of those natures. It was really more about, glasses, contacts, and the surgical aspect of it. And I knew that I wanted to feel that I was making a living, but also I wanted to be making a difference. And I kind of felt like, every patient encounter that I could have or would have, I could just do that, create a sense of worth for both me and my patients. So, yeah, I mean, I knew it was the right path for me when it just kind of allowed me to kind of fly, be a free bird. You know what I'm saying?
Yeah. So many people know you for your collaborative corner vlog on iTube. What do you enjoy most about making those videos?
It's interesting. It's like you said, many people, and I want to thank both those many people for watching consistently. Thank you too. I always felt you just can't really take things too seriously, as you can tell by this. I mean, I try to take that tone in the blog, and I approach my encounters with patients in a very similar vein. Much, unfortunately, to my patients' chagrin, but also sometimes to my human resources chagrin too, when they get those letters questioning, did he really say that? Yes, he really did. I feel we need to demonstrate, professionalism, but we're still have to be relatable. I mean, we're still human, and to me, making these videos is a way for me to kind of try to bridge that gap or bring some of my own personality into the day-to-day activities that we all encounter. You see me on my Peloton sweating like a long-tailed cat in a room with my wife because girlfriend loves cats. I mean, seriously. There's never been a cat that she doesn't want to just squeeze and hug them to death. Socially distancing from my patients with my digital phoropter, talking about how ridiculous using a sock with rights for heating pads is, and drinking my daily celery juice. These are all really true representatives of what my patients see and hear from me day to day. I mean, it's interesting because I still think back to one of the very first videos I ever did, comparing the crystal lens to an M&M. I mean, it's today, to me, still, this is the greatest analogy ever. When you think of your lens in your eye, think of M&Ms. I say that every day to patients, And so these videos, they're me. So it's kind of fun to try to outdo myself, and, I just hope others gain some knowledge, and it's a little bit of entertainment for my tomfoolery.
You are a founding member of the Optometric Council on Refractive Technology. Tell us how you got involved with that.
So the OCRT, now the Optometric Council on Cataract and Refractive Surgery, the OCCRS, interestingly enough, was started in the kitchen of Lou Phillips. Him and Paul Karpecki were sitting around eating, I think, a bowl of pasta, as the OD folklore has it. Lou was schooling Paul on the finer wines of Pittsburgh and lamenting about the myopic decision by both the American Society of Cataract and Refractive Surgery and the American Academy of Ophthalmology to exclude optometrists from attending their meetings as registered doctors. You could go. You just had to basically just pretend you're not who you are. This association was started in response to the need to arm optometrists. And I mean arm, just with education, good clinical data with the most current research, surgical techniques, products, and management protocols for refractive surgery patients. One of the only jobs I really ever had at that moment was working in extremely progressive refractive and cataract surgery centers. So I knew firsthand the role that optometry can and really does play in the care of these patients. So the OCCRS continues to be a group of like-minded ODs who understand just really the important role in our patients' success with surgery. And it's interesting because, the vlog I do is called Collaborative Corner, and everything we do is a collaboration, whether it be between our patients, whether it be between primary care doctors, or whether it be with, ophthalmology. So this group really, to me, is kind of indicative of what optometrists should and what we do.
Mm-hmm. So if someone were to make a movie about Schwartz Laser Eye Center, what actor would play you?
Oh, gosh. It's funny, too, because I mean, I think, people look at me and they just think that your life is a movie. It's a horror film, and it is sometimes. But literally just yesterday, my wife, Jill, was asked to name the title of her life movie to this point. It was her principal at the school she works with. And I suggested her motto, "Don't tread on the crabbo or you will get the stabbo." But I never really gave any thought to who should play her in the movie. Not sure. But what is funny to me is when people say, "You know who you remind me of?" And I say, I really don't care. Because honestly, inevitably, I'm sure it's just going to be sad and disappointing for me. For example, I remember I had been told once that I reminded people of David Cross. And I'm like, really? Really? David Cross. Now, that is wicked bald stereotyping. I mean, seriously, if you go back and look, right, now that I have the beard and the thing going on too, but it's years ago I had a patient say I look like George Clooney. And I'm like, turns out they actually meant Nathan Lane. So that was hurtful. That was really hurtful. So who should star me? Oh, gosh, stars me. I would say maybe Zach Braff. And if he's not available, maybe a little Andy Garcia. Yeah, I don't know.
Those are great picks.
The end. You made it through another episode. Don't forget, you can always read these articles and others at modernod.com, where you can also sign up for a free subscription to the magazine. Next month, we'll feature articles from our October issue, so come on back then. Listen to the Mod Pod for free on Spotify, Apple, Google, or wherever you download your podcasts. And don't forget to follow us on Instagram, LinkedIn, Facebook, and Twitter. Until next time, stay happy and stay healthy.